Hello, everyone. My name is Kyle Allred, course producer here at medcram.com, and welcome back to another question and answer session. Thanks for joining us. I'd like to introduce Dr. Roger Seheult for those who are new to us here at MedCram. Dr. Seheult has 4 board certifications: critical care, pulmonary, and I got to kill the volume here. Sorry, my computer's speaking at me there. 4 board certifications: critical care, pulmonary, sleep medicine, and internal medicine. And Dr. Seheult is also a professor of medicine at both Loma Linda and University of California, Riverside. And welcome back, Dr. Seheult.
Thanks, Kyle.
So you have been working a pretty long stint in the ICU. I know you've been in the ICU quite a bit the last 4 weeks. So I'm going to tee us off with a question here, and hopefully Jack Looney's question, let me pull it up on screen, can kind of lead into a clinical update for our audience on how things have been going in the ICU and maybe the latest from the clinic. So here's Jack's question. Dr. Seheult, and I'm going to modify the question a little bit. In addition to medications, what other crucial changes in ICU treatment have been modified in the latest weeks or months since this pandemic hit the United States?
Yeah, so there's been a lot of things. At first, we thought, well, let's get these people intubated quickly because we want to have source control, get the endotracheal tube down so that we're not spreading the virus around. And we've learned a lot in the last 3-4 months that that's probably not the best way to go, that actually using non-invasive ventilation may save lives, and that trying to keep them off the ventilator as much as possible is the way to go. And even though that may spread the virus around a little bit more, that's the offside of it, because you're aerosolizing the virus and might be getting more infections with healthcare workers. The data at least seems to indicate that that's one area that we've learned is using high flow oxygen, using BiPAP, using CPAP until you absolutely have to use the ventilator. That's one area. We can also talk about other areas like steroids. We can talk about other areas like the remdesivir that's come out. These are areas that we've looked into, and obviously those areas that don't have a lot of risk, like supplement with vitamins and zinc and vitamin C, things of that nature. But I think the big areas that I see is non-invasive ventilation, number 1. Number 2, steroids. Number 3, some of these antivirals like remdesivir. I think those 3 things have made a big difference.
Excellent. And speaking of, let me remove Jack's question here. Speaking of steroids, your last couple MedCram updates you've discussed dexamethasone and how much of a potential game changer this is. We now have more of the data. It hasn't been peer reviewed yet. It's important to note that, but we have more of the data from the recovery trial on the mortality benefit from dexamethasone. So in addition to this question, if you could give a quick recap on using dexamethasone, but I'll go to the question here. This is from someone that was tuning into our medcram.com channel, and they said, we are using methylprednisolone, this is coming from a clinician, with good result. Should we continue to use should we try to use dexamethasone because it's cheaper, or should we continue with what we're using in methylprednisolone?
Yeah, so we look at the best data that we've got right now. That is the recovery trial, which is a prospective randomized controlled trial, and that was with dexamethasone. And so anytime you deviate from the trial, you always institute the question of whether or not that deviation is going to cause a difference in the outcome. So generally speaking, the purist would go with exactly what was used in the trial. In this case, it would be dexamethasone. But we believe it does work through a anti-inflammatory effect, and there's a lot of other different steroids that can do the same thing. 6 milligrams of Decadron is the same as 32 milligrams of Solumedrol, which is the same as 40 milligrams of prednisone. Would it work the same in all of those? Yeah, probably, but we don't know for sure until those studies come out in those other medications. Those other medications do differ slightly in the fact that some are natural occurring steroids. Other of them are synthetic. So Decadron is a synthetic steroid. And so, it might be a little bit different. There's also mineralocorticoid activity with some of these things. So it may increase the amount of salt retention and water retention. So the question is, should you stick with Solumedrol or go to Decadron? We don't really know the answer to that. Certainly, if Decadron became short or you couldn't find it, then that would be a reason to go to Solumedrol. And I wouldn't expect the outcomes to be any different, but we don't know for sure until we get the data.
And could you give just a very quick recap of what the data showed with dexamethasone for folks that have just joined us?
So dexamethasone was one of the interventions that the recovery trial did in the UK. They looked at a number of patients with this and stopped the study short because of the improvement in mortality in two groups of patients. Number one, a group of patients who were hospitalized that required supplemental oxygen. They found that there was a substantial, there was about a 3 to 4% drop in mortality in those patients, which converted into about high 20 number needed to treat to save one life. But the group that really benefited even more than that was the patients that were on the ventilator. And there was about a 35% relative risk reduction there, which translated to a number needed to treat of 9. So that was pretty substantial. It was about a 11, 12, 13% in their reduction in mortality, absolute risk reduction. And so that was big. It's very rare that you'll see an ICU study in ARDS or a respiratory failure from a virus have that much of a mortality drop. And so that was quickly adopted by a number of institutions based on the press release. Now the peer-reviewed or the non-peer-reviewed preprint data is now available on medRxiv, so you can see that as well. And we've given the link to that in our update on MedCram, and you can look at the data there. Hopefully it'll be published very shortly in one of the big journals, either Lancet or New England Journal. We'll see what happens.
Great. Let me get rid of this question, pull up another one. So here's a simple question, and it's simply, where are most people catching the virus? And I'm going to kind of adapt that question to the United States. And Dr. Seheult, before we got on, you shared with me a nice chart. So I'll pull that up while you take a crack at this question.
Yeah, so as you can see, the big states that were present front and center, ground zero at the beginning of this epidemic were in the Northeast. So New Jersey, New York, Wisconsin, those sorts of Michigan, those sorts of places. And they shut the places down. They did a very good job. And now New York is pretty much quiet in terms of coronavirus. They're doing a very good job there. What do we see now? What we see now are different states, primarily, ironically, the states that are the hottest and get the most sun. And so that's kind of an ironic thing because we thought that heat and sunshine would help us, but it's in fact the southern states like Florida, Texas, and California, Arizona that are at the forefront of this second wave, if you will, or maybe the end tail of the first wave. We don't know what to call it really, but there's definitely been a resurgence. A lot of theories behind why that might be the case. Could be so hot that people are staying inside in air-conditioned rooms and enclosures where the virus can spread, and it's obviously not affected by sunlight, not affected by heat because of air conditioning, something that we didn't have in 1918. So this is a little bit different, kind of a curveball. We'll have to see if that pans out in terms of the data. But clearly at this point, you can see that while there are some states really that it's just been sort of gradually increasing, there's definitely a collection of southern states where it's definitely surging.
Great. I'm going to pull another question in here, and it's regarding NAC. From Victoria, there's a lot of talk about NAC. What are your comments on NAC?
Yeah, well, we really don't know. We know a lot of theory, and we've connected a lot of dots. NAC is a it's a relatively natural substance in the fact that it's a bunch of amino acids, 3 amino acids put together. And it also recharges your glutathione peroxidase antioxidant system. It also has a lot of thiol groups. Thiol groups reduce disulfide bonds, which are seen in von Willebrand's polymers. which could be implicated in coagulation and what we're seeing in COVID-19 patients. So there's a lot of reasons why it would be helpful and it would be good, because it would reduce the reactive oxygen species, and it may also break up the von Willebrand polymers that may be causing a lot of the thrombosis, which is causing the morbidity and mortality in COVID-19. But we don't really know. We don't know until the randomized controlled trials are completed. Unfortunately, they are doing one at Sloan Kettering, and there is a trial that's looking at using intravenous infusion of N-acetylcysteine, 6 grams a day. So 6 grams of N-acetylcysteine in 250 cc's of D5W, which is dextrose, and that's infusing at 10 cc's an hour throughout the whole day on these patients. Whether or not it helps, we'll find out when the study gets released. But you can look that up in clinicaltrials.gov and see that that's one of the trials that's going on, and hopefully we'll know more soon.
And just to clarify, NAC is N-acetylcysteine. And obviously on this channel, we're not giving medical advice. We're not replacing any recommendations from your physician. But Dr. Seheult, are you taking NAC?
Yeah, so that trial that I was talking about was an intravenous preparation. You can also take NAC orally. Reason why I'm taking NAC 600 milligrams twice a day is based on some of the data. Some of the studies that have been released back in 1997, they did a study where they gave that dose of NAC, 600 milligrams twice daily, to people going through a flu season. And they found that it didn't reduce the chance of infection, but it did reduce the severity significantly of the symptoms of that infection. And so given the fact that it worked for influenza and that potentially COVID-19 seems to be a little bit more of an oxidative stress type of infection, I felt that it would be worth doing that. The question is there risk in taking N-acetylcysteine at that dose for that period of time? They didn't seem to report any kind of side effects in the study, so I'm going off of based on the evidence there.
One of the things that's been in the news a little bit and that people have commented on is this progression of symptoms, which of course you've seen in the hospital in the ICU. Oftentimes in the second week, and correct me if this deviates from your clinical experience, but in the second week is often when patients, if they're going to develop respiratory problems, if they're going to become hypoxic and need to be on oxygen support, it often starts in the second week. And oftentimes in the third week is when you may see complications with blood clots, thromboembolisms. Would you agree with that general timeline? And then I have a follow-up question.
Yeah, that seems to be what's coming out of New York and also our experience as well.
And then speaking of thromboembolism and clots, I want to pull in this question from Alfonso regarding thromboprophylaxis, preventing clots. When should it be started? And then the follow-up question is, does D-dimer level alone, and Dr. Seheult, you've talked about D-dimer in some of the MedCram videos, should that be the guide for starting enoxaparin or a anticoagulant similar to enoxaparin?
Yeah, so we don't really know at this point. There is a test that can be used where they actually they take a clot on a pivot point and they measure how strong the clot is, and they can tell you is there a problem with clotting or DIC with thrombin, with platelets, with thrombolytics, things of that nature. That is being looked at. I think the kind of the dirty way of looking at it is a D-dimer, but I don't think that explains everything. There's been some data that's looked at this. Certainly, people with higher D-dimers seem to do worse than people with low D-dimers. There's some hospital organizations that are using a cutoff of 1. There are some hospital organizations that are using a cutoff of 3. In those situations, they are using full dose anticoagulation either with Lovenox or with intravenous heparin drips. They're also keeping these patients on it. Now, we've seen obviously complications on both sides with thrombosis in patients and also bleeding. So this is something that you have to watch very carefully. You may have a thrombosis in one part of the patient and bleeding in another part. So what do? You have to sort of mitigate and look on both sides of that equation. The data seems to be indicating, at least in some of these papers that are coming out, the recommendation is anyway, that this clotting ability, or this predilection for clotting with COVID-19, may last for quite some time. And at least some institutions are recommending and doing this, anticoagulating patients after they're discharged. There's some papers that have been talking about with rivaroxaban, discharging them with rivaroxaban, which is a oral anticoagulant when they go home, to prevent these blood clots from occurring.
Great. Thank you for that. And I'm going to pull in another question here. And it's about antibody tests. And we also had a viewer that just wrote in wondering if you, Dr. Seheult, have been tested for COVID-19 antibodies. And I don't know if you want to comment on that, but if you do, you can.
Yeah, in the last few months, I have been tested. Earlier on in the beginning, was tested and it was negative. So,
okay.
Of course, you can get false negatives. The problem with these antibody testing when you don't have a high prevalence is you can get a lot of false positives. And so if your antibody is positive and you have a very, very low prevalence, you don't know if it's positive because you really actually have antibodies or if it's positive because it's just a false positive. And so you may decide to alter your behavior thinking that you're actually immune when it's a false positive. So that's the problem with these antibody tests when there's a very low prevalence, which currently there is relatively.
Right. And Betsy had a specific question here. Does a positive antibody test mean you can't spread the disease?
Oh, no, it doesn't mean that at all. In fact, you could actually be positive on the PCR and have a positive PCR test, meaning that you actually have the virus in you and then have the antibodies. So the antibodies show that your immune system is responding to the virus, but it's possible to still be infectious even though you have the antibody. Certainly, that's still a possibility.
Okay. Another question here about quality of life. So this is kind of I apologize if this is too small for folks to read at home, but I'm going to read part of Tim's question here, which is that he'd like to hear from Dr. Seheult about how much quality of life would generally or roughly remain after surviving a situation where one is potentially on a ventilator in the ICU, treated for COVID-19. So obviously, and I'll add to it, we don't know with COVID-19, there hasn't been enough data on the long-term sequelae or what happens to patients after they get COVID-19. But Dr. Seheult, from your experience dealing with other viral illnesses that might cause similar clinical symptoms as COVID-19, acute respiratory distress syndrome, etc. If someone gets on the ventilator, and they recover and they get discharged, is there a good chance that they go home and life resumes to normal, or do a lot of these patients have some long-term lung damage that they're dealing with? What's been your experience?
So the quick answer is that there is always going to be some lung damage that occurs when people have lung injury from ARDS or from COVID-19. The question, though, that really has to be answered to answer that question in a specific individual is how much damage has happened and how much reserve did they have to begin with. And that's going to determine the answer to that question. So if somebody came in with absolutely no lung disease, that's what we call a perfect or a normal forced vital capacity, and they got some lung damage, your lungs are overbuilt. So you're able to actually have a, somewhat, respectable quality of life if you burn through some of your lung function with COVID-19 and ARDS. If, on the other hand, you didn't have a lot of lung function to begin with, and you were sort of getting by, this may be the thing that causes you not to be able to get off the ventilator, requiring you to have a tracheostomy and require ventilator support for the rest of your life. And so it really is a case-by-case basis. Yeah, certainly the data from influenza and ARDS show that there is a modest amount of decrease in forced vital capacity after one of these types of bouts where you're in the intensive care unit on the ventilator for some period of time. Whether or not it's enough to knock you to a point where your quality of life is beyond, good, it really depends on how much you had to begin with and how much you were on the ventilator.
So a follow-up question along those lines, I'm sure a lot of our viewers have had um, a pneumonia in their life. With something like pneumonia, same thing. Do you see a little bit difference in their lung function test? Maybe they don't notice it, but can you notice
No,
that clinically?
I'm thinking more in terms of people who have known lung disease, like for instance, they've got pulmonary fibrosis already, they have cystic fibrosis, they have COPD. These are the sorts of things that, if added to that, was a bout of respiratory failure on the ventilator from COVID-19, that might be the thing that tips them over the edge and prevents them from getting off the ventilator. As the inflammation starts to occur in COVID-19 in the lungs, it causes a fibrotic phase, and that fibrotic phase makes the lungs very stiff, and it takes a lot of energy to move your lungs to be able to breathe. Once you get to that point, the quality of life kind of goes down. Unless, of course, you had that ability, beforehand, then that might be something that you could mitigate.
Thanks, Dr. Schwelt. Here's another question from Cheryl, and it's, how do doctors learn about the latest treatments to try? Does an alert go out? How can we be sure that our doctor is using the latest information?
So this is the way it works. The most popular and the most large guideline clearinghouses, if you will, would be the WHO, the CDC. Other places would be like proprietary platforms like UpToDate. That's a place where doctors can get a subscription and log in. These organizations are probably the most authoritative. And as a result of that, what they say really has a lot of weight. Because of that, they tend to be very conservative. They will not say that anything works unless there is very, very good data. The last thing that they want to do is say that something works when it doesn't work. And so, yes, those are very widely available. And so you will get the standard of care out on those types of platforms, especially UpToDate. If you go to UpToDate, you'll see what the latest is. They'll even tell you about some of the things that are in the wings and are being looked at, but they will not recommend it because it hasn't yet shown a randomized controlled trial that shows that it works. Now, as you start to go down and look at other areas, you might get articles, you might get journal articles, you might get societies, you might get podcasts, you might get things like MedCram, where we look at certain interventions that may or may not work, that seem like they might work based on the data that maybe is not in humans, maybe it's animal data, maybe it's in vitro data, maybe it's retrospective data. So again, all of the type of evidence that's not really the gold standard, which is the randomized controlled trial. And we may say, hey, here's something that may work. It looks like it works, but we don't know for sure. But hey, look, it really doesn't cause a lot of risk. I mean, what's the risk of these risks are very mitigatable, in other words. And so that's the type of stuff that you might not see in UpToDate. You might not see in some of these bigger articles. They might want to wait a little bit longer, in other words, to see if it works and pass muster before you include that. And those are the types of things that you probably aren't going to see universally seen in physicians and hospitals across the country and across the world, because people have different levels of comfort in accepting recommendations when there isn't that type of gold standard randomized controlled trial. So I hope that answered your question.
Yeah, I think that helps. And the second part of it, Dr. Schwelt, you work at 2 different hospitals in Southern California. How much variability is there between, for example, those 2 hospitals in how you treat severe COVID-19 patients?
Yeah, so even at just those 2 hospitals, we have different testing contracts. In other words, the COVID-19 test comes from different places. They have different pharmacy networks that they get their medications from. And so, yeah, there are some subtleties and differences. In this case, though, the infectious disease specialist that works at one also works at the other. So that kind of unifies it. And of course, the pulmonary groups are the same as well. So in that sense, there has been more unification in terms of how we do it than you would normally expect in these kind of a situation. But yeah, certainly, definitely things are different.
Okay. Next question is from Ezra Steinberg. What are the other long-term effects from COVID-19 and the risk of needing months to recover fully from the disease? And I'll add to this that, of course, Dr. Seheult, you're working in the ICU, so you're not really in a position necessarily to see patients for follow-up. And I know there's so much we don't know about this, but I know this is on a lot of people's minds. If I get COVID-19, what are the chances that I'm going to be dealing with this for not just a week or two, but months?
Yeah, so it's one of the problems. We don't know. 80% of these people don't even need to go to the hospital. 20% go to the hospital, and with some of the data that I'm seeing there, it's improving. Maybe 50, 60, 70% of them are being discharged. So that's kind of where we are. The people that are having worse times are the ones with elevated BMIs, elevated high blood pressure, things of that nature. So I think we had some data coming out of New York at the very beginning. We should have some more data coming out here in terms of the characteristics of these patients and who they are and who are at more risk. But historically, we know who they are. Those are the patients that are overweight, elevated BMIs, cardiovascular disease, kidney disease, diabetes.
Okay, and speaking of risk factors, I'm going to pull in another question here from Quentin Baca. Do higher levels of glucose hinder our body's ability to respond to SARS CoV-2? And I know you've done a video.
Well, we know that it does in terms of bacterial infections, but whether or not it does SARS CoV-2, we don't know that answer yet. We do know, though, that patients with normal hemoglobin A1Cs and elevated glucose when they come into the hospital seem to do worse. We don't know if that glucose is causative, and therefore, if we give them insulin to bring it down, it would improve things, or whether or not that high glucose is just a marker of what else is happening in underneath the hood.
Got it. And you mentioned bacterial infections there, and that's really where we have some data on how, even high sugar diets or high levels of glucose can impact that. How often are you seeing secondary infections in your COVID-19 patients in the hospital? Meaning they have COVID-19, but they also at some point get a bacterial infection that they need to be on antibiotics for?
I am not seeing it very often. It's pretty rare. What we are seeing with equal frequency, unfortunately, is people coming in with antibiotics who are getting C. diff infections. And as a result, C. diff is Clostridium difficile. It's a infection that occurs in the bowel as a result of misuse of antibiotics. So I think the recent data is about 10% of patients with COVID-19 will have a concomitant or simultaneous bacterial infection. So if you're seeing more than 10% of the patients with antibiotics, you're probably using it too much.
Got it. Okay, as I wait for more questions to come in, any other clinical updates from the ICU that have been interesting to you, or things that you're watching particularly in the research that's coming out?
I think the area that I'm most interested in is the area of anticoagulation. And I think there's some good data coming out that shows that, yes, we ought to be doing anticoagulation. We probably need to be doing it as they're going home on discharge, and probably for a month or two afterwards. I think 45 days is what they're looking at. There's some good data out of Mount Sinai, New York, that I think we need to look at that a little bit more carefully. The other thing that we're looking at is remdesivir and its use. It's going to be interesting here in the next couple of months, because we're going to be starting to get into a situation where we're burning through the 1.5 million dosages that we had. And so we might see a shortage of remdesivir as we go on further. The other area that I'm looking at is whether or not we should be giving tocilizumab, which is that IL-6 inhibitor, in addition to steroids, and whether or not that improves. There's some interesting data that seems to indicate that in a hospital system that was using this, and we'll probably need to do a MedCram video on this, is about 75 to 80% of those people on ventilators were surviving when they were given steroids and tocilizumab. So I think that's exciting. We'll have to see how that goes.
I'm going to pull in a question, Dr. Seheult, that even hopefully for our clinicians watching this, this will be review for some of them, but just sometimes the way that you explain things really helps me out, and that's just in broad strokes. There's a question from Mary Wood. What is an anticoagulant? How do these medications work?
Okay, so that's a good question. An anticoagulant is something that prevents your blood from clotting. And because there's a whole very complicated clotting cascade that occurs, there's many different points where it can inhibit it and cause the coagulation not to happen. There are different factors. And so heparin is one that works kind of near the top in multiple places. Coumadin is one that we've had for years that basically reduces the body's ability to make a number of different factors, 2, 7, 9, 10. CNS are those factors. And then there's direct antithrombin inhibitors and factor 10A inhibitors. So those different medicines have different ways of attacking that clotting cascade. The end result is generally the same. You don't form a clot. And that is important in situations where you don't want clots. That would be in atrial fibrillation, in stroke, and we believe now in COVID-19. And so starting people on anticoagulants may be very beneficial in these type of patients.
Great. This is a question from Melanie. Have you seen a lot of red eyes as a symptom of COVID-19?
Actually, I have not, interestingly. I know that conjunctivitis is a symptom. Certainly, there's ACE2 receptors around the limbus of the eye, and that is a potential place where it can come in. That's why we wear face shields when we go into the hospital. But I have not seen that.
And then another question here. That's the same one. Sorry. Pull the other one in. And this is from Chris Monk. Does your hospital receive kickbacks for more COVID cases?
You know, it's an interesting question. Certainly, I'm not aware of any that we get paid for seeing COVID-19. I think what may be happening, and it gets into the way that hospitals get paid. Some hospitals get paid based on a capitation type of an arrangement. So in other words, there's a population of patients, and that population of patients pay the insurance company for health insurance, and then the health insurance company will give all of a certain section of money to the hospital and say, here's a bulk of money per member per head. Take care of these patients, whatever they need, you're responsible for it. And so the hospital is incentivized to spend as least amount of money as possible to take care of these patients as much as possible so they don't need hospitalization. And in those kind of arrangements, and it's not every single healthcare organization or hospital, in those arrangements, the hospital is trying to do as much as they possibly can to decrease the utilization of those patients in the hospital, realizing that they have to do what's the standard of care. In other situations, like for instance in Medicare, certain types, they have something called a DRG, where the patient comes in with a specific diagnosis, then the insurance company will pay the hospital a certain amount of money for that diagnosis, regardless of whether or not the patient needed all of that money to take care of them or not. It's kind of like an average, how much you average take. So where this rumor may be coming from, I'm trying to think, is perhaps there's a COVID-19 DRG. So if a patient comes in with COVID-19, this is the amount of money that the hospital gets to take care of that patient. And so, you know, it's almost like a capitated type of arrangement. If the hospital can take care of that patient for less money, they get to pocket the difference. If the hospital unfortunately takes more resources to take care of that patient, then the hospital eats it basically on how much more money. We hope that in the end the average works out and that they figured out exactly how much the DRG should be. It's called DRG, stands for Diagnosis Related Group. Mm-hmm. So that's you're learning economics from an MD here, and I'm not the expert certainly in this situation, but I'm not aware of any kind of incentive that I'm aware of for a hospital to say that this patient has COVID-19. I can tell you for a fact that we have rapid testing in the hospital. If the patient comes in and they test positive, they get diagnosed with COVID-19. If the patient is not, then they don't get diagnosed with COVID-19. I would say, is it possible for somebody to come in with COVID-19 but have a completely different diagnosis for why they're there? Yeah, certainly it's possible. I'm not seeing it a lot. It's possible for someone to come in with, for instance, an infection on their skin, cellulitis, and they have COVID-19. Yeah, sure, it's possible. Not seeing that a lot. And so if the patient continued to get worse and die because of a infection of a cellulitis on their skin, the death certificate is up to the physician to write that down. And he's certainly not getting any kickback or incentive. He would write cellulitis. That's what I would write if that patient died of that. Now, there's a little space on the death certificate that say, other complication or other things that might be going on in the patient, maybe not directly related to the cause of death. Yeah, you could put COVID-19 in there, but officially the cause of death in that patient would be cellulitis, not COVID-19. So there is ample resources and ample space on death certificates to really elucidate what you believe is the cause of death in these patients. And to say that hospitals or physicians are getting a kickback and they're getting paid thousands of dollars to put COVID-19 down on death certificate, if that's the case, well, they've left me out of it. I haven't seen anything like that. Just doing what we normally do every single day, going in and out.
It sounds like a complex system, the capitation system, and
Yeah.
I'm sure you're thankful you don't have to deal with that too much.
Yeah.
A lot of questions. I've been watching the questions here about labs and what for a patient that's admitted to the hospital with COVID-19, what labs are you getting on them?
So the ones that we like to follow are the inflammatory markers, in addition to all of the other things that we normally get: CBC, CMP, chest X-ray, blood gas. These are things to monitor critical patients that we normally have in the hospital. But what's special about these kind of patients, other than getting a COVID-19 test, we would get a ferritin level, which is an acute phase reactant. It has nothing to do with what we think the iron store is. Ferritin is a surrogate marker for inflammation. Another one in that category is CRP. CRP is a C-reactive protein. That one also goes up and down depending on what the inflammatory markers are like in the patient. In addition to that, we look at the D-dimer. Why? Because that's telling us what the clot burden is. And it's a very rough way of looking at it. It may not be the most elegant way. It may not even be the most accurate way. There may be better ways of looking at it, as we've alluded to before. But those are ones that we get typically on a daily basis. Another one that we may get is procalcitonin, because procalcitonin levels seem to correlate with bacterial infections, not 100%. But if we see a patient who's decompensating and their procalcitonin level starts to go up, that may cause us to signal us to think about, well, maybe this patient's developed a rare secondary bacterial infection, and to go reculturing and looking for bacteria and thinking about starting broad spectrum antibiotics in these patients. So those are the things that we get. Chest X-rays, certainly if these patients are on the ventilator or if we're concerned about worsening, we would get that. Blood gases to measure their ability to exchange oxygen and get rid of carbon dioxide. So these are all things that we get in these patients routinely.
Great. Well, Dr. Seheult, do you have time for a few more questions? I know you have to get back to the ICU this evening, actually. So how are you doing?
Let's give us. Yeah, I've got a patient that's they have some questions about, so I'm going to be getting back here shortly. But maybe I can take one more question.
Okay, let me grab one here. Let's see. Oh, tocilizumab. There's been some questions about that, and specifically the role of that medication after someone's been given steroids. So it sounds like there's some new data coming out. Hasn't been peer reviewed yet. Not even sure if you've had a chance to look at it yet. But looks like there may be a role for it. Some good numbers coming out. Any thoughts on that?
Yeah, it's just come out. I haven't had a chance to look at it. It sounds like it's promising, and that sounds very, very good. Tocilizumab, of course, is an IL-6 inhibitor. Steroid is kind of like a blunt force object on the immune system. It doesn't really hit specifically like a target like tocilizumab. But if that's the case, then that would certainly be very, very encouraging. We need something like a tocilizumab steroid combination. More data to come out. We will see.
Excellent. Well, thanks, Dr. Seheult, for joining us. And how does this week look for you? Do you think you'll be able to get some videos out this week, some updates?
Yeah, we've got some interesting topics to talk about. There's no shortage of that. So I think look for a video tomorrow morning and maybe a few more this week.
Excellent. Well, thanks again, Dr. Seheult. Thank you, all of you, for joining us this evening and for your questions and for tuning in to our MedCram channel at YouTube and our website, medcram.com. As we mentioned every time, we have a lot of other topics. Dr. Seheult has great brief videos on a variety of topics, from heart failure to diabetic ketoacidosis to acid-base problems. So check us out there, and we'll try to do this again in a week. and we'll hopefully see you all then. Thank you. Thanks again, Dr. Schwalt.
Thank you.